My name is Shelbi Rochin, and I am a D&P student at Maryville University. Today, I will be presenting my quality improvement project titled Symptom Burden for Congestive Heart Failure Patients at Home, a Best Quality Initiative. First, I'd like to start off with introducing the committee. So, Shelbi Rochin, the student and researcher who is myself, Dr. Constance Bowen, who served as the chairperson, Dr. Maria Snell, who served as the 705 faculty as well as the second reader, and Ms. Lauren Willis, a licensed medical social worker who participated as the community member. So to start off and cover a little bit of background on the project, heart failure patients make up over 30% of home health admissions, and frequent hospital readmissions and billions of dollars spent every year. Home health providers are trusted and expected to provide assessment to patients and report findings of their comprehensive assessments to assist in disease management and hospital admission prevention. However, this is often missed. The Edmonds Symptom Assessment Scale Revised has been used for decades as a symptom assessment tool and expands across multiple settings and disease processes. This project aims at identifying the need for proper symptom assessment and reporting in the home health setting. Measured outcomes include scale compliance, symptom burden scores, hospital admissions, palliative or hospice referrals, and reporting compliance. The goal is to show that the scale can be used in the setting to improve the quality of a clinician's assessment. So the ASR has been used for over 25 years. It was originally created for palliative care and oncology, but has since expanded into multiple different disease processes. It has expanded into various circumstances and shows excellent rapid assessment assistance, especially regarding a patient's condition. Multiple topics have used this scale in order to assess, similar to what a triage scale would, and to rate patients on severity of symptoms. One of the most important projects that was quoted during the quality improvement was the Dihawal et al., used by over 500 patients. So they did a similar assessment in a similar setting. However, this project had over 500 patients as opposed to the 13 in this trial. And it reported a 6% symptom score for severe. This will become important when we compare the 31% of severe symptom scores in this population. The framework chosen for this specific location and setting was the model of strategic management of change. The theory was used to show how to integrate the what, why, and how, and is a fundamental part of the model. Since this project explicitly works with the clinicians, we have to make sure that the education fits the setting. Home health clinicians are famously independent, and they need to know what they are doing and why and how they are expected to implement something. Combined with that, this setting had a very unique culture, and I had to find what best fit to ensure the highest chance of success and clinician buy-in. The model used at this project level was the PDSA model. It was used to ensure the proper implementation of the QI process. PDSA models typically include multiple rapid assessment cycles where we can rapidly assess information, create a baseline, and have the option for additional cycles with interventions. And so that's why I chose this model. However, this project was a single cycle project. The question of inquiry was answered, which was to address improved care for patients with CHF. The results included decreased hospital admissions, improved assessments, and improved hospice and palliative care referrals. So in looking at the setting for this project, this took place in a home health agency within Southwest Idaho, encompassing 6 towns across the Treasure Valley. Participants included home health clinicians within the home health agency, and this was to include all specialties. Physical therapy was included, all occupational therapy was included, and that also includes their assistive staff, such as PTAs or CODAs. Skilled nursing, which encompasses both LPN, LVN, and RNs in the home health setting. Speech therapy, and licensed medical social workers. The charts that were included were of clients who had signed consents and primary diagnosis of CHF. So their admitting diagnosis to the home health agency had to be one consistent with CHF. Since this home health agency only sees adults, it was included in the criteria that they had to be 18 or older. Data analysis was performed looking at compliance and reporting, and they were measured using percentages from the total. Average symptom ratings were measured using the mean of each specific symptom and the total patient ratings. So each individual assessment did have a symptom burden score, as well as for each individual symptom across all patients, across all scales, to get an average of which symptoms were the most severe for the patients. Hospitalizations and hospice or palliative referrals were compared to pre-intervention data, and all data was analyzed using a custom Excel document created specifically for the project. Results and outcomes. These are measured in 5 different outcomes. So to discuss outcome 1, we're going to look at the compliance with the scale's use. 79% of patients used the scale during an 8-week period. There were 95 total visits that occurred during that 8-week period, meaning that 75 scales were completed and documented. Outcome 2 is the reporting compliance. This is where a clinician got a severe score on a symptom, and it was under their instruction and proper use of the scale to report this with the provider. Only 8%, meaning 2 of the scores, were properly reported. Overall, out of all 13 patients, 9 of the patients had a severe score. And of those 9, 3 of them chose to seek some sort of higher level of care or an inpatient admission. So in home health, seeking a higher level of care includes the emergency room, urgent care, skilled nursing, any kind of additional setting of care. However, an inpatient facility only counts if they are admitted, not under observation, and admitted for 24 hours. 0 patients without a severe symptom score, required admission. So of the 3 patients that had severe scores, they all had severe scores within 5 days of seeking additional care. So on table 2, you'll actually see how the scales are broken down to provide how many scales did have a severe rating versus an average of a moderate rating versus an average of a low rating. Outcome 3, of the 3 inpatient admissions during the post-intervention period, so after the scale was in place, 1 of the admissions resulted in an inpatient admission. So that's that over 24 hours mark, admitted not under observation. If we compare this to the 21 patients that were formally admitted inpatient in the pre-intervention period and look at their diagnosis, 3 of them were admitted due to congestive heart failure. So regardless what they were admitted to the home health agency for, 3 of them still had complications of heart failure, resulting in a hospitalization. That puts the congestive heart failure admission rating at 14%, compared to the post-intervention data of 7%. Showing that a decrease in hospitalizations due to congestive heart failure is noted in the post-intervention group. Outcome 4, 31% of patients had at least one severe symptom score during the project period. Compared to other projects in similar settings, this population almost tripled the severe scores, showing there was a significant need for comprehensive assessment, but also proper reporting. And I am going to pop back to figure 1 for a second just to build off of that. When we talk about the average score, that is the score that was averaged between all of the scales for a specific symptom, and they did have the same, what would be considered debilitating symptoms. So the tiredness, drowsiness, fatigue, and shortness of breath still remain the main symptoms reported by patients across almost all of the studies reviewed. And it also was found in this project. So they are having the same symptoms and the same needs. It just shows for a fact that they are more severe because we had a 31% symptom rating of severe. Outcome 5 discusses hospice and palliative care. So 0 patients in the pre-intervention group resulted in a palliative or hospice care referral. 1 patient was admitted to hospice during the project. Since this scale has been used in palliative care, an increase shows that the scale can be used to identify these needs in the setting chosen. So in figure 3 and figure 2, you'll really see a focus in on that proper reporting of that 31%, so the proper reporting of the severe scores. Limitations. So every project has limitations, and this one was no different. One of the largest limitations was the clinician and management turnover. So right before the project began, they actually lost a branch director, leaving an interim branch director to assist the director of operations as the branch director. So with the change in management, obviously comes some sort of change in culture for the providers and the patients that are admitted to the branch. So regaining trust and managing turnover was a big part of the project itself. This also goes into the second limitation of education. So staff needed additional education for proper reporting. So if this were to be performed in a second cycle, that's where that would come in. However, all clinicians were provided the same education across the board, keeping in mind that an experienced home health clinician will have a better understanding of what is expected of them in an independent setting like home health than a new practitioner in a home health setting. And sample size was another large limitation. So with home health, there is a very large wax and wane of different admissions and diagnosis. Smaller sample sizes and limited pre-intervention data were limitations, and these are uncontrolled by the researcher, and they directly relate to admission rates. So because there was less admission rates for congestive heart failure, we did have less patients in the setting. So to start the discussion, we can ask the question of, in home health patients with CHF, does the implementation of a tool for symptom burden lead to increased palliative care intervention? Well, we know that the answer is yes, because in 8 weeks we had more palliative care, including hospice referrals, than in the pre-intervention period. Additional findings show that the scale also improved their assessments. Proper reporting could have prevented or decreased the hospitalization rate, and the relationship between severe scores and inpatient admission or seeking a higher level of care existed, and identification of symptom severity in this specific community. So what I mean by that is that until we assess the severity and the need for something, we may not know that it exists. When looking at the implications to practice, this was broken down in 2 ways. Future research, the scale shows the ability to be used within the setting, identify declines, and opportunity to implement interventions and prevent hospitalizations. On a larger scale, This can be used to improve patient outcomes, decrease spending and adverse events, and improve quality of life and clinician assessments and relationships. When we specifically note on this community and nursing in general, CMS is the Center for Medicare and Medicaid Services. They are the ones who regulate home health and hospice agencies, and they are the ones who also assist in deciding what regulations are followed as well as reimbursement. So naturally, because they are the regulating body, any adverse events or never events do get reported to CMS, and not reporting a symptom is an issue, and it is tracked as well as hospitalizations. So if we decrease that, we can improve CMS agency outcomes and improve healthcare spending cost. We also have the opportunity for improved education for nurse leaders. Nurse leaders are often tasked with educating new staff, and it is, from my experience, under the assumption that all clinicians are trained the same, whether you're physical therapy, a nurse, a social worker. They may not have the training for the same assessments, but that does not mean that the ESASR is outside of their scope. This provides better education for nurse leaders and guidance on how to assist them in providing comprehensive assessment. The next was actually noted specifically during the scale's use in this setting. So, as we talked about before, home health clinicians are famously independent. It's not uncommon that they don't even know the names of other staff members. They work alone, they go to the patient's home, and then they go to the next patient's home, and they don't really have a home office or a home setting or a home nurses station where they're meeting. They meet usually once every week to every 2 weeks to discuss patient conditions and plans of care, but that's a meeting focused specifically on a specific group of patients and not on actual team building. Being able to use the scale in the setting provided an incentive for improved outcomes for the clinicians. They wanted the patients to do better. They wanted to prevent hospitalizations, and they wanted to communicate those issues with their fellow clinicians and assistive staff to make sure the patient was improving. So not only does that improve the outcome for the patient, it also increases team building for the clinicians and gives them almost a new lease on proper communication, proper reporting, proper assessments. There is also the note of preservation of patient integrity to prevent any kind of bias, whether that is racial, gender, political, religious, socioeconomical. This is a standard baseline. All patients are assessed using the scale and asked the same questions that are on the scale, and it is recorded. This prevents any kind of bias because the standard is placed already. So in the professional conclusion, it is important to note that the project was performed in an HHA that focused on improving the care for CHF patients, but also on the skills of clinicians. The use of the scale has had a positive impact, including the continued use within the HHA, noted positive feedback from the clinicians, and it set roots to continue to improve patient care and drive towards better practice. Best practice. On a personal conclusion, I feel this project has helped me build relationships, grow my research and educational skills. I've learned to work towards such a rigorous process and furthered my love for the profession. These projects and the programs can often feel endless. However, the accomplishment felt coming towards the end of this journey has been a huge milestone in my professional education. I am forever thankful for the guidance of my chair, university staff, husband, and family who have been by my side through this educational journey. And I want to thank everyone for watching the presentation, and I've included the citations here for you to read. And thank you for listening.